My patient is a 38-year-old male subject from Murshidabad, was admitted with history of shortness of breath and palpitation. He also gave history of balloon mitral valvotomy about 7 years back. He got admitted in the ICU and we did the echo in our lab. The finding is, we found that he is having thickening of both anterior posterior mitral valve leaflets with dilated LA, prominent LV, and there was also thickening of the aortic valve. The mitral valve opening was restricted. There was mild subvalvular fusion. So immediately our diagnosis came out to be a rheumatic mitral valvular restenosis, and he was treated accordingly, and the patient was in atrial fibrillation. So as soon as we got the patient of this rheumatic mitral restenosis in atrial fibrillation, we tried to ascertain what grade of severity the patient is having. So as we can see, visually we felt that the stenosis was severe with moderate grade of calcification of both anterior posterior leaflets. The posterior leaflet calcification bit somewhat more, and we also tried to find out what are the associated valvular lesions the patient is having. So we, from parasternal long axis view, we went into the apical 4-chamber view. We found that his LV was also a bit prominent. The LA was, as we told, is dilated, and but surprisingly the RA and RV was not so thick, not so big. So our diagnosis was mainly mitral valvular restenosis. As soon as we put on the color Doppler, we found that there was mild to moderate mitral regurgitation with a flame-shaped mitral stenosis jet. So we wanted to quantify the degree of mitral stenosis. So we changed the view from parasternal long axis to parasternal short axis view, and we selected the proper plane using the multi-D mode, and by planimetry we calculated the mitral valve area, and it came out to be around 0.9 centimeter square. And to confirm, we tried to find out actually by the 3D whether the valvular stenosis is severe or not. We found that actually there is a huge chunk of calcification in the posterior mitral leaflet with a severe degree of probable stenosis. So in all the levels, we found that there is severe degree of stenosis. Now we found by planimetry the degree of stenosis was severe both by 2D method and by 3D method. So next step, we tried to ascertain the degree of stenosis by pressure half time. So we changed the view from apical from parasternal long axis and parasternal soft axis to apical 4-chamber view, and we put on the continuous wave Doppler across the both leaflets of mitral valve, and the patient being in average atrial fibrillation, we calculated the mitral valve area for at least 5 to 6 cycles, and the mitral valve area by pressure half time method, that is Hartley's method, it was around 0.62. So it correlated well with the planimetry calculation. The mitral valve area is 0.62 and by that method it is 0.82. So, it is severe mitral restenosis. Now, while calculating the mitral valve area by pressure half time, we carefully selected the proper the median slope, leaving out this the early tall part, because this is the sky slope area which as per recommendation has to be left out to calculate the mitral valve area by pressure half time method. So, by pressure half time my mitral valve area was 0.62, and by auto generated formula from our machine we also calculated the mean mitral valve gradient across the mitral valve. That was for consecutive 5 cycles, it was around 3.6 to 3.4 millimeter mercury, and this portion of the mitral gradient did not correlate with the severity of the stenosis. But as we all know, it may not correlate with all the methods may not correlate with each other while calculating the mitral valve area. So, and the next step of calculation of mitral valve area is we used continuity equation, where we found that by continuity equation we calculated the aortic valve area diameter in the parasternal long axis view, and then calculated the VTI of the aortic flow, and by dividing this product by the mitral valve VTI we found out the area of the mitral valve, and that also came out to be 0.49 centimeter square. So, by these 3 methods, the pressure half time, planimetry and continuity equation, we got the result to be severe mitral restenosis with moderate degree calcification of mitral valve with mild subvalvular fusion, and if we calculate the Wilkins score, if we go via the degree of thickening of the anterior mitral valve leaflets, the degree of calcification, the mobility and subvalvular thickening, I will put it around 6 to 7. So, my conclusion is this is a case of severe pliable mitral valve restenosis. Now, next we wanted to assess the degree of mitral regurgitation in this patient. So, to assess the degree of regurgitation, whenever there is regurgitation, one must ascertain 3 things. One, whether it is a rheumatic or functional, but this step we skipped because we already know the patient is a known patient of rheumatic valvulitis, and so it was rheumatic mitral regurgitation. The next step was degree of or the severity of mitral regurgitation. If we look at the picture, naturally the immediate eyeball method, the impression is you are having a mild mitral regurgitation, but still this is a very qualitative method. The semi-quantitative method is calculation of vena contracta. Vena contracta calculation can be done both by 2D method and the 3D method. So, vena contracta method calculation, you calculate the vena contracta or the diameter of the jet that is emerging immediately out of both the leaflets of mitral valve during the diastole. So, this should be remembered, the vena contracta method, the mitral valve, the area came out to be or the thickness came out to be 0.3, and the third and the most important method is via PISA method. For PISA, you must have three things. One, the PISA velocity, the radius of the MR jet, and the Nyquist velocity. So, we calculated the PISA, the regurgitant jet by PISA, and the PISA radius was, MR radius was 0.82, aliasing velocity was 0.36, and the flow rate was 153 milliliter per second. Now, we traced the mitral regurgitation rate, and the ERO came out to be 0.3 centimeter square. This suggests the mitral regurgitation is mild or borderline moderate. It's most probably the degree of regurgitation is mild, because the MRO should be less than 3, it's mild, 3 to I think 4 it's moderate, and more than 4 is severe. So, my case is mitral regurgitation of mild severity. Now, next step is, my patient also has a very atypical finding. As we can see, he has mild TR, severe rheumatic mitral restenosis with mild TR, and without pulmonary hypertension is not so common. As you can see, the pressure TR gradient is 6 millimeter mercury. So, calculated pulmonary pressure is around 10 to 12 millimeter mercury. Now, his IVC is not plethoric and collapsing with inspiration. So, there is no systemic venous congestion, but peculiarly he has got severe systolic dysfunction. When we did study of his right ventricle, we found that his fractional area change was 20%, his TAPSE was 2 millimeter, and the free wall RV free wall strain was minus 3.6%. So, this implies he has got RV systolic dysfunction. So, my subject has severe mitral restenosis, pliable, with mild to moderate MR, with mild TR, without pulmonary hypertension, with biventricular systolic dysfunction,